The next topic is on the diagnostic evaluation of open angle glaucoma in the present scenario, and the speaker is Dr. Andrew Braganza. Dr. Andrew Braganza is a professor of ophthalmology. We all know him very well, CMC Vellore. He has spent most of his medical career at CMC, right from his MBBS, except probably for a few years when he did his MS at PGI Chandigarh. He is a doyen in the field of glaucoma, we all know that, but he has also done a lot of good work in strabismus and neuro-ophthalmology. He is a teacher par excellence and an examiner for undergraduates and postgraduate students in ophthalmology in the states of Tamil Nadu, Kerala, Pondicherry, Karnataka, and also for DPNB. Dr. Andrew Braganza.
First of all, thanks to the KSOS for inviting me. I love coming here, mainly because of the food, but the scientific content of this conference I have found admirable, and the way it's organized. So it's a pleasure to be here. Anyway, so when I was, just doing my post-graduation, diagnosis of primary open-angle glaucoma was a three-legged stool, and it was IOP, disc, and fields. And if you have 3 legs, then you can create a stool and you can sit on it and it will bear a whole lot of weight. It's still the same, but the terminology has changed a bit. So IOP is IOP, but now we have functional tests and structural tests, but we still have only 3 legs to stand on. If we go into the details of each of these legs, it's not that things have stayed still. We've become more and more technologically aware. We have technologies which have been applied to make us more accurate in how we measure each of these, the parameters that we measure to help us to our diagnosis. So in IOP, Goldman applanation tonometer was and still is the gold standard, and it must be measured in every patient. Having said that, even though Goldman is likely to continue as the gold standard for some time, we have found the need to try and monitor intraocular pressure at various times of the day, in various other situations. So there are many other tonometers. And to my mind, one of the best is the dynamic contour tonometer, because that takes the corneal thickness out of the equation. And the rebound tonometer, eye care, and there are several other devices. Interestingly, there are also devices where you can measure intraocular pressure through the eyelid. Accuracy and all that, okay, but there are patients in whom other means of measurements are not possible, and measuring through the eyelid offers a safe way for the patient to monitor their own intraocular pressure if you can figure out what sort of correction you have to apply. The latest is a contact lens sensor where you can continuously monitor the intraocular pressure, and it's kind of passing it on to a device which will pick up all this information, and that's very promising. Does the Shiot's tonometer still have a role? Surprisingly, it possibly does, because it's one of the only ways you can clinically measure intraocular pressure after a keratoprosthesis. So use the Shiot's tonometer on the inferior sclera, and you get some indication of the intraocular pressure. So don't completely count it out of the picture. The role of intraocular pressure in diagnosis of primary angle closure glaucoma is based on the fact that we have time and time again proved that it is causally associated. We know about all the inaccuracies in measurements, etc., and we can correct for them. We know that there's a great individual variation of normal IOP, which is why it's so difficult to diagnose glaucoma in the first place. We know that the fluctuations in intraocular pressure can affect the diagnosis and the treatment. About 40% of primary open-angle glaucomas at their first presentation have a normal intraocular pressure. So we need to get a little more information about that, and we used to do a lot of diurnal variations of intraocular pressure, which we don't do anymore, not because it's a valueless test, but because it's so cumbersome and difficult to do, time-consuming, resource-consuming. And by resource, I don't mean financial resources. It takes up our time, and we need to have enough people to do that. So continuous monitoring of intraocular pressure, etc., is likely to contribute a lot in the diagnosis of primary open-angle glaucoma in the future. We have functional tests also. So full threshold automated static automated perimetry is the gold standard, but it's a psychophysical test. And a psychophysical test needs an intelligent, cooperative subject. They have to understand what's required of them and they have to perform. It also has statistical interpretation, which means that the more data that we have, the better we can get, the better sort of result we can get, which means every decision has to be made on at least 2 visual fields. Okay, that's the recommendation, the strong recommendation from all glaucoma authorities. We don't always do it, but that's the recommendation. FTP has been used. It's a slightly different modality. And in children and patients who are unable to perform automated perimetry, it can help in the diagnosis. When you can't do any of this, then you do careful combined manual, static and kinetic perimetry. And again, very time consuming and resource consuming. So why do we need to test function? Okay, why can't we just say, okay, disc looks like this and that's it? That's because there's a wide interpretation of structural tests. So, the functional test becomes very important. We often see patients in whom the most sophisticated imaging is abnormal, but this is not reflected in the fields that we test. When we commit to primary open-angle glaucoma treatment, we commit the patient to treatment for life. And that means to potential serious adverse effects, which can be medical, because of medical treatment, can be because of surgical treatment, because we say, okay, I have to reduce your intraocular pressure by 30% or 35% or whatever, according to my other studies. We will have to operate. And the TRAB is not an easy operation, nor are any of the other, devices that we use easy operations or without complications. And even laser treatment has its problems. So the functional aspect is the weakest leg of the stool. We desperately need an objective measure of function. And the possible candidates for this are really electrophysiology based, where you can use ERG, you can use pattern ERG, which is okay. You can use multifocal ERG, which is really not proving to be very useful. And you can use this, photopic negative response, which is probably better than the other. You can also use a VEP-based objective visual field testing, and all these are being developed but are nowhere near clinical use for us yet. A nice wrinkle on the standard automated perimetry is the virtual reality-based, head-worn, sorry, I'm really taking up a lot of time, perimeters, and these are possibly more reliable. When we come to structural tests, we have the clinical binocular magnified stereoscopic disc examination as our gold standard. Stereoscopic disc photographs reflect this but give us a permanent documentation. We have disc imaging with multiple modalities, but finally comes down to OCT, OCT, and OCT. Most of the others are not really very much used now because OCT is a very flexible machine and everybody has it. Ocular blood flow, yes, plus minus. The important thing about OCT is that instead of just looking at the retinal nerve fiber layer thickness, which is what we do right now, we also have minimum rim width and thickness. We have the GCC analysis, which has been fairly promising, but most promising to my mind is the OCTA-based blood flow. And the question in this is, which came first, the chicken or the egg? And currently the evidence is that we are leaning towards a more vascular mechanism of damage in glaucoma than structural damage. Is there a fourth leg? That's the big question. And there are many candidates, but to my mind, the best candidate is a genetic association. There's a huge amount of work going on in genes, and we are already aware of family history, race, all these as risk factors. Gene analysis is now widespread, and several new genes have been identified. Polygenic risk analysis may be of use in diagnosis. It is definitely of use in making treatment decisions. And I'm hopeful that we will be able to look for expressions of genetic anomalies which will give us diagnosis. We leave this out. There's no single gold standard for primary open-angle glaucoma diagnosis. So what do? We continue with our three-legged stool, but make every effort to refine the quality of data that you put in, objectively evaluate each new technology that comes, and keep our minds open and receptive to change. Thank you.
Thank you, sir. Just a momento. Yeah. I request Dr. Prashant to kindly please give the moment. I wish there had been more postgraduates and fellows, because it was such a basic class. It was so good actually. I think many of them missed it.